Thank you for inviting us to present this UK dietetic survey looking at dietetic time and ketogenic diets. These are our disclosures. During this presentation, I'll discuss the background of the project, give details of the survey, and highlight the key results. I'll then hand over to my colleague Rachel, who will discuss the results and limitations of the study. There will be opportunity to ask us questions in the live question and answers at the end of this session. The ketogenic diet is recognised as an effective treatment option for drug-resistant epilepsy. It is a resource-intensive treatment, with dietitians being recognised as an essential member of the multidisciplinary team. They are necessary for the implementation of the diet and to support the patient throughout their ketogenic journey. Despite the recognition of the importance of the dietitian, there is very little data on the time spent fulfilling this role. Previous studies have suggested that the implementation and monitoring of the ketogenic diet has been estimated to take between 8.5 to 50 hours of dietetic time per patient. This is dependent on the ketogenic diet type, feeding route, and patient age. The last decade has seen the continued increase in popularity of the ketogenic diet for drug-resistant epilepsy, and there has been an expansion in the number of ketogenic centres in the UK and Ireland. So with this in mind and the reported medical cost benefits, it was felt that an investigation of dietetic time and patient numbers involved would be useful to inform providers making epilepsy healthcare choices. So this was a joint project that was undertaken by the Ketogenic Dietitians Research Network, KDRN, and VitaFlow. And the aims of the study were to investigate the time taken by dietitians to implement and manage children and adults with drug-resistant epilepsy on the ketogenic diet, and to generate information to support future expansion of dietetic services. Look at the methodology. So an online survey was developed by a consensus group of ketogenic dietitians. The survey link was circulated via email to all KDR members working in a total of 39 ketogenic diet centres across the UK and Ireland. Data was collected between the 3rd of June and the 5th of July 2019 and was requested only for patients who were on the ketogenic diet for the management of drug-resistant epilepsy. Dietitians were asked to categorise their patients by type of KD variant, feeding route, and type of enteral feed. They were also asked to give the average number of hours spent on patient-related activities on a per-patient basis during a keto patient journey. At the end of the survey, dietitians were invited to use free text to describe and identify any factors they considered impacted their time spent managing patients on a ketogenic diet. So for the purpose of this project, the ketogenic diet was divided into 3 types. So there was the classical, the MCT, and the modified KD. The feeding route was divided into oral only, tube fed only, and combined tube fed and oral. And the enteral feed type was divided into 3 categories: proprietary, bespoke, and blended. In the survey, when we refer to a proprietary ketogenic feed, we mean a liquid or reconstituted powdered feed based on the classical ketogenic diet. This feed is used as it is with no extra ingredients added. A bespoke ketogenic feed is a modular ingredient feed or a proprietary ketogenic feed with extra ingredients added. And the blended ketogenic feed is a feed made from real food ingredients. The patient's journey was divided into different sections. So there's the pre-diet preparation, the 3-month trial, the 2-year follow-up period, and the diet discontinuation. So the data was analysed using Microsoft Excel. And responses were received from 15 dietitians representing 9 UK NHS ketogenic diet centres. 6 centres provided a service to children only. 1 centre provided a service solely to adults. 1 provided a service to patients aged 13 plus, and 1 provided to all age groups. The data was obtained for a total of 335 patients, of which 80% were 18 years or under. Let's look at some of the results that we obtained from the survey. So the first pie chart refers to the type of diet that the patients were on. So 56% of the patients were on a classical ketogenic diet. So all those who were on a classical ketogenic diet were children. So this is followed by 39% on the modified ketogenic diet and 5% on the MCT ketogenic diet. The second pie chart looks at the route of feeding. So it was found that 60% of patients took the ketogenic diet orally, 35% were solely fed via a feeding tube, and 5% were on a combination of both tube and oral feeds. And the third pie chart shows the ketogenic diet journey. So out of 335 patients on the ketogenic diet, 10% were in the pre-diet preparation stage, 11% were in the initial 3-month trial, 46% were within the 2-year follow-up period, and 6% were being discontinued from the diet. It is also worth noting that 27% of the patients had been on the ketogenic journey for more than 2 years. So this bar chart shows the estimated median dietetic time spent per patient during the dietetic journey by diet type and feeding route. The first 3 bars represent the 3 types of oral diet, followed by the 3 types of enteral feeds, and the last bar is for a combined tube-fed oral KD. The bars are also divided to show the time spent for each of the different stages of the patient journey. So we can see for orally fed patients, the classical ketogenic diet required the most dietetic time, with a median of 193 hours per patient, followed by the modified ketogenic diet with a median of 104 hours per patient, and the MCT diet with a median of 95 hours per patient. For ketogenic diets given solely as an enteral feed through a feeding tube, it was found that the time spent was highest for blended feed with a median of 189 hours per patient, compared to those on a bespoke feed with a median of 162 hours per patient, or a proprietary feed with a median of 85 hours per patient. Overall, the patients who required the most dietetic time were those following a classical ketogenic diet via a combination of tube and oral feed, with a median time of 211 hours per patient, whereas those solely tube-fed on a proprietary feed took the least dietetic time with a median time of 85 hours per patient. As part of the survey, we also looked at the estimated median time spent during each stage of the ketogenic patient journey. So we find that during the pre-diet preparation stage, there were 3 groups of diets which required the greatest dietetic time. So they were the oral classical ketogenic diet, the blended feed, and the classical diet given as a combination of oral and tube feed. So all took a median of 12 hours per patient. Patients following the oral modified ketogenic diet required the least amount of dietetic time with a median of 4 hours per patient. During the 3-month initial trial, patients on blended diet took the most time with a median of 72 hours per patient, while those patients on a proprietary or a bespoke feed took the least time with a median of 24 hours per patient. Over the maximum follow-up of 2 years, patients following a classical ketogenic diet given as a combined oral and tube feed required the greatest time with a median of 144 hours per patient, while those in a proprietary feed or the oral MCT ketogenic diet took the least time with a median of 48 hours per patient. The dietetic time required for the discontinuation and return to usual diet was greatest for a bespoke feed or a blended feed with a median of 8 hours per patient, and lowest for the modified ketogenic diet with a median of 4 hours per patient. Of the 15 dietitians who completed the survey, 12 dietitians, or 80%, had patients who had been following the ketogenic diet for longer than a maximum 2-year follow-up period, and the median estimated time dedicated was 2 hours per patient per month.
So dietitians were asked as part of the survey about groups of either patients themselves or their caregivers who potentially need additional dietetic time and support to establish and maintain them on the ketogenic diet. Patients identified as needing extra time included infants, toddlers, and young children, particularly those who were weaning or experiencing periods of rapid growth. And this is obviously because these patients would need very regular review by their dietitian with frequent tweaks to ensure their changing requirements were being met. Other groups identified were adults with communication challenges, such as learning difficulties, poor numeracy or literacy or technical skills. And these groups often necessitate increased time for preparation or adaptation of education resources to ensure that they're suitable for their needs. Those with food allergies or intolerances or any dietary self-restrictions or poor tolerance of the ketogenic diet. Obviously, any further restrictions onto the already limited intake on a ketogenic dietary regime increase the dietetic time required to ensure ketosis is achieved and maintained, and also to ensure the nutritional adequacy of the diet. And it may be that they need extra time to get information on specific specialised kind of prescribable products and things as well. Those with complex medical conditions or comorbidities that need to be factored into their management, and those who have multi-agency involvement or who live perhaps in specialist accommodation. And obviously these groups involve wider networks of carers who the dietitian would need to link in with to educate and communicate with regularly. Characteristics identified in the caregivers included learning and communication challenges and language difficulties. And again, that's for that adaptation and preparation of suitable resources, suitable for their needs. Those with health and mobility issues affecting their ability to cope with the practicalities of the ketogenic diet. So for example, carers who may struggle with the shopping or weighing the food or the practicalities of preparing and administering the ketogenic diet may need things adapting to ensure they're achievable and realistic for those carers. Those with challenging behaviour or anxiety or the need for extra reassurance. And this group may have lots of questions and need extra time and support from the dietitian. And also those whose health beliefs or dietary preferences are not in alignment with the ketogenic diet evidence base. And this group may need quite a lot of persuading and convincing with the evidence base and the benefits of the diet for the person they're caring for. Dietitians were asked how many hours per week they were officially allocated to provide their dietetic service to the patients with epilepsy on a ketogenic diet. And for the 15 respondents, there was a total of 445 hours per week, which equates to just short of 12 whole-time equivalent dietetic posts. A full-time post in the UK is also referred to as a whole-time equivalent, or WTE, and that equates to 37.5 hours a week. And it's generally how dietetic resourcing is quantified for kind of like-for-like comparison, as many staff work part-time with a varying number of hours. 12 of the 15 respondents, so 80%, did have help in their team from a dietetic assistant and or an epilepsy nurse specialist. And certainly our personal experience in our team, having relatively recently had consistent involvement of a dedicated ketogenic dietetic assistant, we can absolutely verify how much of a difference that can make to the overall efficiency of the team. And just over half of the respondents felt that the use of a ketogenic meal planner like EKM could be a time saver. Departments were generally resourced with Band 7, so senior specialist dietitians with Band 6 or senior dietitian support. And just to put that into context, in the UK, a newly qualified dietetic post is Band 5, increasing to Band 6 or Band 7 with experience and expertise. And also just to note, many services are built on the provision of a 2-year ketogenic follow-up. So as a result of that, any patients who do stay on the ketogenic diet beyond that 2 years can increase the pressure on the resources in that team. So the survey went on to ask if the official time allocated is reflected of the actual time spent managing these patients. And 2/3 of the respondents, so 10 of the 15, said no, it wasn't. And they were asked, if not, to give reasons why not. And the reasons given were the complexity of the caseload, and other job-related tasks such as line management duties, clinical cover for colleagues, and training such as CPD, student training, and training other healthcare professionals. We're also asked to give an approximate time difference between the official allocated and actual time spent in hours per week, and this was estimated at between 4 and just under 14 hours per dietitian per week of extra time to manage both the caseload and their additional duties. So on to the discussion. The median estimated dietetic time per patient with drug-resistant epilepsy for their full ketogenic diet journey was estimated as 162 hours. As we've heard from Catherine already, the classical diet, administered either orally or as a combined oral and tube-fed feed or as a blended ketogenic enteral feed, were the ones that took the greatest amount of dietetic time. The estimates of time taken in this survey were higher than previous reports, so why might this be? Any differences in estimates of dietetic time for any ketogenic diet type may be influenced by a range of different factors, really, including the range of patients referred in terms of their complexity, and this can have a greater or lesser impact on the time, depending perhaps on the experience of the dietitian involved in their care. Also, the level of support required. So we've seen previously from the characteristics in the patients and the caregivers that there are many factors that can increase the time and support they need. And country-specific dietetic practices such as funding and other practices. And the previous UK data, interestingly, is closer to that of our results than that from an international work. Resource availability is obviously also a factor, so the experience and the skill mix within the dietetic team and whether they have the support, for example, the dietetic assistant or an epilepsy specialist nurse. So the survey results indicate that certain ketogenic diet types and feeding routes are more time efficient than others, but obviously the choice of a ketogenic diet type is not just driven by time, although that may be a factor to consider. By their very nature, ketogenic diets are highly individualised, so that prohibits the automatic allocation of specific dietary prescriptions or standardised initiation protocols and meal plans that may be a time saver. Medical and nutritional needs of each patient need to be taken into account, and an example of this might be that a more time-consuming bespoke or blended ketogenic enteral feed may be indicated rather than the proprietary feed, due to a patient having allergies or intolerances, or to meet very specific individual requirements such as low energy requirements in a child with low physical activity levels. Social circumstances need to be taken into account. So, for example, modified ketogenic diets may be favoured in older children and adults due to the palatability and also their social acceptance, rather than the fact that they're less time consuming. The preferences and abilities of both the patients and caregivers obviously do need to be taken into account, and we always work with them as much as possible. And also the clinical evidence base. So, for example, the classical ketogenic diet has been demonstrated to show equal clinical efficacy for seizure reduction versus the MCT, but is more effective than the modified Atkins for the 1 to 2 year old age group. And we mentioned earlier about the use of a ketogenic meal planner being a potential time-saving tool. So this can be factored in. For example, a time-consuming oral classical ketogenic diet can be much less so in terms of dietetic time if there's an able caregiver or patient themselves who can be trained to be more independent with the recipe development and adaptation. And it may be that training on the use of the meal planner might be something that could be a role for a dietetic assistant, thereby releasing more valuable dietetic time. As with all studies, there were some limitations to this work that we need to consider. It was done as a retrospective survey with estimated times rather than a formal prospective workload time analysis. And this was deemed to be the most pragmatic approach, placing the least demands on the respondents. The survey wasn't validated, and there was the potential for research or imposition as it was designed by a consensus group of ketogenic dietitians. The children represented in the caseload of the respondents, the patients, sorry, represented by the respondents were mostly children, with I think 80% being 18 or under. And the difference in the dietetic time between the management of children and adult patients wasn't assessed in this work. The journey is very much depicted as a smooth continuum with 4 defined stages with progressive completion of each stage, but in reality that doesn't always happen. There can be interruptions that occur both related to the ketogenic diet and not. And although 39 centres were invited to participate, there was a relatively low responder rate, with only 9 centres being represented in the responders. But interestingly, there were 335 patients reported on the caseload in those who responded. And Vicky Whiteley and KDRN's work in 2017, so 2 years earlier than this survey, reported that there were a total of 754 patients on ketogenic diet in the UK at that time. Obviously, this survey is 2 years later, so those numbers are likely to have changed. But it's just interesting that despite the low responder rate, there seemed to be a good number of patients represented in this work. So obviously practice in the other centres who didn't respond from the UK and the Ireland remains unknown, and it may be difficult to extrapolate these UK NHS specific results to other countries. But despite these limitations, this work does provide unique insight into the time spent by dietitians managing patients on ketogenic diets. No previous study has investigated dietetic time required to manage them in conjunction with consideration of the varied ways in which these diets are administered. So this work gives a really comprehensive view of the time at each step of the journey, with the diet type and the feeding route taken into account. Provides really valuable information for planning the initiation or expansion of ketogenic diet services in the future. And further national and international research is always warranted, including prospective dietetic time data collection and perhaps an estimate of time by other healthcare professionals involved in the management of these patients to give a complete picture of all those involved in their dietary management. So on behalf of VitaFlow and KDRN, we'd like to extend thanks to all those who contributed to the work. This is a lovely picture from a KDRN meeting a couple of years ago, before COVID or social distancing were even a thing. And Catherine and I just wanted to thank VitaFlow again for the opportunity for inviting us to present this work. And there will be an opportunity for question and answers in the live Q&A at the end of this session. Thanks very much.